Welcome to Talking Meds on the Prescript podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to Talking Meds. I'm your host, Jonathan Underhill, and I'm joined today by Dr. Lucy Pollock. This is the fifth in the series of podcasts on sensible prescribing in older people with Jonathan and Lucy. Lucy, what are we going to talk about today?
Jonathan, hi, it's nice to be here. We are going to talk about a really tricky one, which is statins. So we're also going to talk about knowledge and ignorance and evidence and what we don't know and what matters most.
Okay, great. Lots of people will be very familiar with the prescribing of statins in our precious older people. This is something that comes across all the time in medication reviews, isn't it?
Yeah, it's a really tricky one. So I thought we might start by thinking about a patient. So this is a patient who's actually, I know from personally rather than from my professional role. But we've given her a different name and I've anonymized some of her details. But Mrs. Evans, let's think about Mrs. Evans. She's 87 years old and she has lived in annex of her daughter's house for the last 5 years or so. She's become a little bit more frail with age, and she had a stroke about 6 months ago. She's got quite a long old history. She's had diabetes and hypertension for a long time. She was diagnosed with heart failure with preserved ejection fraction a couple of years ago. And then she's had this stroke, but she made it home. But now she is really struggling. Her daughter says, you know, Mum, the sparkle has gone out of her eyes. She's feeling pretty low. Her mood has gone off. She's struggling with everyday tasks. She says, you know, I just can't be bothered to do quite a lot of these things. And her daughter mentions that Mum says, what's the point? What's the point? She looks at the handful of tablets that she's got in front of her and she shrugs her shoulders and she says, what's the point? So we can have a bit of a think about her medicines. You might be able to guess what some of them are, I think, Jonathan.
Yes. I'm guessing she's on metformin for her diabetes, maybe a bit of insulin, perhaps?
Yeah, exactly that.
The standard candesartan, bisoprolol, dapagliflozin, felodipine, all those sorts of things.
You're right. So she's on quite a few medicines for her hypertension. She is, you're right. Candesartan, felodipine, exactly that. Dapagliflozin because of the HFpEF. Yeah. She's been on citalopram for quite a long time since her husband died. She takes some amitriptyline every night, 20 milligrams. She takes regular paracetamol. She's got quite a lot of osteoarthritis. And of course, since the stroke, she's now got some clopidogrel and 80 milligrams of atorvastatin.
Okay, 80 milligrams of atorvastatin, because that's what it says in the guideline, doesn't it? If you've had an event from NICE.
It does. And so the big question is, her daughter said to me, I just don't know whether these tablets are worth Mum's time, and Mum doesn't like taking them. So the really big question for Mrs. Evans, and I'm not her doctor, but the conversation that she needs to have is with somebody who really knows what they're doing in terms of prescribing, a really cracking prescribing pharmacist or her GP, and sit down and think about what's important to her, what difference are these medicines really making for her? Because of course the atorvastatin, among several of her other drugs, is not making any difference to how she feels day to day. It's a risk modifier. It's changing very slightly the risk of something happening in the future.
So that's an important thing, isn't it? Because taking atorvastatin 80 milligrams is very unlikely to make you feel better, is it?
I mean,
it may well reduce your risk of having a future event, but it's not going to make you feel any better. And if anything, what high doses of statins do is sometimes they cause muscle fatigue and muscle pain, and they can maybe make your liver function go off, and that can have consequences. So it doesn't happen to everyone, but the risks are there and have been documented in the clinical trials and in pharmacovigilance studies. Higher doses of atorvastatin can cause these issues in especially in older people. So as we said, it's not going to make her feel any better. It's not going to help with her
No.
symptoms. If anything, that might add to her symptoms.
Exactly. Now, of course, we know patients who actually literally do feel better when they take a statin because they're really keen on their medicines. They've got every faith in them. They look at the handful of tablets and they think, I'm glad I'm taking those.
Yep.
I've got
Okay.
patients who are like that, and that's absolutely fine. You know, you've had a scary event and you think, I want to do everything I can not to have another one. I'm very glad I'm taking these tablets, and I positively feel better when I'm taking them because I feel they're doing me good. But that wasn't the case for Mrs. Evans. So then the next question is, you're absolutely right, Jonathan. So the question is, you know, that's a big old dose of atorvastatin. That's your high intensity, high dose statin, for which there is the best evidence base, but we know that there are problems with side effects. So would it be sensible just to cut it down to 20 and say, okay, we hope that you're going to get some of the benefit there, and we suspect you'll have fewer of the side effects? So that would be one option. The other option is, do we just stop it altogether? And there it comes down to that really important thing about the patient's view, but also about accepting that we don't actually know whether that tablet is doing this lady any good in the long run. We don't know whether she's going to be the one person that benefits in a medication that has a significant number needed to treat, or is she going to be one of the many people who are going to take it and it's not going to make any difference at all. We also don't really know whether the evidence base applies to Mrs. Evans, because actually, when you look more closely, the studies of statins have mostly excluded. They've included quite a lot of older people, but they are still done mostly in people in their early 60s. There are older people in the studies, and there are meta-analyses of all the older people in the studies. But when you look more closely at the inclusion and exclusion criteria, you will find that on the whole, they exclude people who have got more than mild frailty. So anybody with moderate to severe frailty, as well as being a bit older, tends to get excluded. So if you just look at the Sparkle trial, for example, you had to be functionally independent with their measure was a modified Rankin scale. You had to be functionally independent to get into that study. And the other thing is that the investigators could exclude you if you might be unreliable, and that would include any form of psychiatric illness, which for a lot of people would include dementia. And the average age in that big trial was 62.8. Yeah, it's pretty young, isn't it?
So Lucy, we talked a few weeks ago about GP evidence, didn't we? Which is a really useful website. Julian Treadwell, a GP, is producing. It's excellent, and we've recommended it before. We'll put the link again in the show notes to this. But if you look on Julian's on GP evidence, for people who've had a cardiovascular event and take atorvastatin 80 milligrams, out of 100 people, and you're right, Mrs. Evans wouldn't have been included in these trials. But if we just take that as, if we accept that and we jump to and we sort of extrapolate that from the studies, out of 100 people, 29 people will have a further cardiovascular event over 5 years, and 71 won't. If all 100 take atorvastatin 80 milligrams, then that reduces from 29 people to about 22 people out of 100 who will have the cardiovascular event. So what you've done is you've saved 7 people, prevented 7 people out of the 100 from having a cardiovascular event. But of course, 71 people will neither be harmed nor benefit from taking a statin. That's the sort of thing that you need to weigh up, isn't it, when you're making these sorts of decisions.
And you can use the same website to look specifically at people who've had a stroke, recent stroke or TIA, and look there. And again, you'll find a number needed to treat of 53 to prevent another stroke. And for any cardiovascular event, as you say, a number needed to treat of 15.
Sorry, Lucy, but the other thing as well is because Mrs. Evans has already presumably got her blood pressures treated and is controlled. She's on metformin. Presume she doesn't smoke and she has a reasonably healthy lifestyle, perhaps. You've actually reduced her risk quite a lot already. So you're not starting at a risk of 30% over 10 years. You may be starting at a much lower risk. So there is this law of diminishing returns that when we add in interventions, that the benefit that you achieve is lower because you're starting with a lower risk in the first place. But of course, the harms increase because you're adding in more medicines. And it's a real dilemma for prescribers, isn't it?
Yeah, it does get very complicated. I mean, of course, in the big trials, most people would have had their hypertension and diabetes addressed alongside the statin. So we have to be careful not to read too much into that. But the bottom line is that for an individual, we know that on balance they're probably on balance they're probably not going to benefit from this medication, but they do stand a chance of benefiting in terms of reducing the risk of a cardiovascular event. So this brings us on to our problem with actually not knowing and with uncertainty. And how does one share that uncertainty? I was listening to Rory Stewart on the radio the other day talking about ignorance. And he said something really interesting. He said, we need to deepen our knowledge, but at the same time, we need to deepen our understanding of our ignorance. And I think this is something that we don't like accepting, particularly as prescribers. We think, oh, it would be much better if I show that I know everything here and I'm going to give you really strong, good advice. But actually, having some humility and saying, actually, I really don't know. This is what I do know, and this is what I don't know. That can be an uncomfortable place to be. But equally, it's also quite an honest place to be. And you can do that, but without looking like a mug. You're not saying, oh, everybody else knows this and I don't. You're saying, actually, none of us know whether this is a good idea for you to take this medicine. And what you can do is share a bit of that uncertainty and then also frame it around the fact that those numbers needed to treat and the evidence base not being very good, particularly for somebody who looks like Mrs. Evans. That lady is almost certainly not in one of those trials.
I think that's why those icon arrays that you got on GP evidence are really helpful, because you look at that and it really helps illustrate the uncertainty, because you don't know whether Mrs. Evans is going to be one of the green faces where it's not going to happen anywhere, one of the red faces sadly where it will happen anywhere. Or one of the yellow faces where she's safe from that. And you need to have that conversation and say, look, we don't know what's going to happen to you. And as you say, there's a bit of bravery in that, actually. Yes. There really is.
There is. And then there's also a thing about the burden on the people making the decision, which in this case may well be her daughter who's supporting her with this decision. Because actually, the other thing that can happen is maybe we stop the statin and she does have another stroke, which may be a fatal stroke. And her daughter thinks, oh, was that because we stopped the medicine? And what we need to say there is actually chances are stopping the statin or continuing, it didn't really make any difference at all. No. She was always going to have that next stroke. Exactly. So don't feel bad about that. You can make a good decision that comes out wrong because that actually was going to happen anyway. So
we have lots of conversations with people on the national polypharmacy action learning sets that we do with the HIN in Wessex about this very thing. If I stop the statin and the person then goes on to have an event, the family are going to blame me for stopping the statin. And we say to them exactly what you just said. And also, if you do it by informed consent and you've explained the risks and benefits to people and you've documented it, then actually medical legally you're probably covered as well.
Yeah. So in the end, we don't want anybody to feel bad about the decision. It's a perfectly good decision to make, to say, I'm going to stop this medicine, share it, and it's a good decision for a family to make. It's a good decision for a patient to make, and it's a good decision for a doctor to make. You're going into it with your eyes wide open. You're sharing the information, and we all know that we actually we don't know exactly the answer. And then there are other people who are very, very cautious, and they're going to say, actually, I'm going to take every medicine that you've got. But most older people, and certainly knowing Mrs. Evans and knowing her current situation, I know that she will feel more comfortable on fewer medicines, and that's just going to make her feel better. And then it comes down again to this conversation about what's important to you. And there was another really interesting, I'll try and find a reference for it so we can pop it in a link, a lovely study recently presented at the British Geriatric Society about older people with frailty and their views about quality versus quantity of life. And increasingly, this is something that's very familiar to most people. You have that conversation, and families and your patient themselves will say, I don't want to live to live forever. I actually just want to feel a bit better. And that's a really important conversation to have. And if your pill burden is really dragging you down, then one of the ways that you can feel a bit better is by doing some of that de-prescribing. For most people, as I say, there are others who say, oh no, I like the medicines, thank you very much, and I'll keep taking them all, they make me feel secure. Right. That's completely fine.
Because we're all different, Lucy, aren't we? And the only way you know what people's values and preferences are is by asking them and having that conversation with them or with their loved ones. And that's what we have to do as clinicians.
Exactly that. It all comes down to human beings being quite complicated, very individual, and a bit unpredictable, and very interesting to get to know. And that is really been over and over again, I think, the message of all of this stuff about prescribing in older people. We've got to understand our pharmacology, we've got to understand our medicines, we've got to we've got to understand disease processes. So it's hard work, there's lots of knowledge involved, but at the same time, what we really need to understand is what our patients want from us.
Absolutely, it's that attainment of wisdom that we're trying to get to, isn't it? Where we become wise practitioners. I was at a conference last week where I was asked by pre-registration pharmacists, as trainee pharmacists, how do we get clever quickly? How do we so we can attain this confidence? And you say, well, experience. You can't. There's no shortcut to experience. You can't just develop experience really, really quickly. What you can do is you can facilitate learning. And learning from things that either go well for you or maybe when they don't go well for you, and bad things happen to you. You either make a mistake or you try something and it doesn't work. That's where the real learning comes from. That's where you can accelerate that, but you can't accelerate experience, I don't think.
I think that's such a brilliant thing. I mean, it's a really good question, and it's what we all want. It's what I wanted when I was a young doctor. You know, there's so much uncertainty. Am I going to make a mistake? Have I got this wrong? How do I learn this? How do I become like my boss who seems to know everything?
Exactly.
And so there's lots to learn. Pin your ears back, listen to your patients, watch their faces, talk with their family, reflect on what you've learned, and then and gather your pharmaceutical knowledge, grab all the resources that are to hand. How fantastic to have a BNF at the tip of your fingers now the whole time. But also remember that actually we don't know everything, and there's a lot we don't know, and being honest about that is a very good place to start too.
Absolutely. Thanks for that, Lucy. Another fantastic conversation. Thank you so much. We're back in 2 weeks' time where I speak to Dr. Julian Treadwell about his fantastic resource, GP evidence. We've talked about that lots already on the podcast. We've talked about it today as well. But we talked to Julian about what it is, how you use it, and what the plans are for that for the future. So we'll see you in 2 weeks' time for that. Bye.